Welcome to the University of California, San Francisco Sports Medicine Podcast featuring Dr. Nirav Pandya, Dr. Brian Feeley, and Dr. Drew Lansdown discussing hot topics in sports medicine and society.
All right. Welcome, everybody, to this week's 6 to 8 Weeks podcast. We're joined by Drew Lansdown, who's one of my partners, and we have the pleasure of having Leon Scott, who is a physician at the University of Vanderbilt or Vanderbilt University. He is an expert in a lot of things. He is a pediatrician by training, but has come into adult medicine and specializes really in the non-operative management of a variety of different things, but in particular for today, for arthritis. Leon went to WashU for his medical training and residency, and then went to the Harvard University for his fellowship. So welcome, Leon. Thank you very much for being here.
Thank you. Appreciate it. Also, a shout out to St. Louis University, where I did part of my residency and other training too. So all those programs, very important.
Awesome. I should note that Nirav can't be here because he is currently boning up on how to do an ACL. He wanted to read his anatomy text a little bit extra. But can you tell everybody a little bit about what you do and how you ended up in the current practice that you have at Vanderbilt?
Yes. So I started off, like you mentioned, in pediatrics. My focus during early training was always around youth athletes. I wanted to start a practice where we provided comprehensive care for youth athletes because everything, even the flu, is a sports injury for someone who's high level in their upper teens and early 20s. So in that practice, really focused a lot on ultrasound guided procedures, really focused a lot on athletic nutrition, in addition to the more traditional treatment offerings that we provide, casts, splints, medicines here and there. And then in private practice, for a host of reasons, was closing that down, and Vanderbilt was one of their surgical team. They were the people who I referred to the most frequently. So it was a natural fit for me to come into their fold. In the office where I am in Spring Hill, Tennessee, we did not maintain the high school contract. So my practice started off with the kids, their parents, and their grandparents. And then as our high school contracts changed, the team I take care of is not geographically very close to me. So I kept the parents and the grandparents, and we keep the kids, but I'm not their first go-to. So their issues are often sports related, but are more in line with degenerative issues that have an acute flare. So my focus on sports nutrition turned into a focus on nutrition to affect joint function, primarily through weight loss and sometimes through different food composition. And then the focus on ultrasound guided procedures for hip labral tears or shoulder labral tear symptomatic treatment turned into the ultrasound guided treatment of knee, hip, shoulder osteoarthritis with the use of steroid when necessary, orthobiologics, HA, and even 10X for local tendon issues. And that has been the kind of fulfilling intersection of my original training in sports performance and keeping people on the field, and then the patients who are coming to see me who have other pathologies and stages of life, and at different peer ages, there are going to be different items that need to be addressed. So thankfully, my team, my department, my division has allowed me to kind of spearhead the treatment of osteoarthritis with things we all know we want to use, but finding ways to actually utilize and mobilize them so that they are productive for the office and for patients.
And with arthritis, it sounds like you're doing a lot of work with osteoarthritis of the knee, shoulder, and hip. Why is it such a growing problem, or do you see it as a growing problem at all?
Well, I'm told that it's a growing problem. We have estimates from different national groups that show us currently that 30 million Americans have arthroplasties of the knee or hip, and the expectation is that within 10 years that's going to be 60 million. So at least a problem with the number of people who are converting over. It appears that 45% of the country has knee arthritis, 20% of the country has hip arthritis, and we associate a lot of that with our weight, with our body habits, and it all makes sense. So yes, I do think it is likely becoming a bigger and bigger problem. And if I had to, to answer your question in another way, if I'm pointing to one thing, I think it's a matter of mechanics. Arthritis is just, by definition, joint pain, arthralgia, plus the objective change of something, often radiographic, but maybe a fusion, maybe some other change, rubor, tumor, calor, all those things. And if it's not autoimmune, and if it's not crystalline, and if it's not infectious, then the mechanical osteoarthritis is likely that mechanical contribution. So I think one small component is we're playing more sports. So we are adding a risk of a mechanical injury that may start off as a knee contusion with a small, if we had the chance to scope at the time of the injury immediately at the pickleball court, we might see that there is a small defect in the cartilage there that goes through a process that at age 10 would heal up nicely, but at age 50, 60 may get stuck in a process where it is constantly trying to mill down the surface and getting re-injured, and mill down the surface and gets re-injured. And eventually the body goes, cool, enough of this. Like, we're not getting a chance to heal. It may be the repetitive use at a place like a local factory where it's that repetitive motion. One of my theories, and this is truly a theory, one of my theories is that as we see in youth athletes, there is a change in the anterior thigh and posterior thigh strength where it's a 1-to-1 ratio. And then something around age 13, especially in females, seems to create a proportion where the ratio of strength is 2-to-3 posterior to anterior, where the hamstrings are about 2/3 as strong as the quads. And I suspect that when we take a look at a joint like a knee, which has a nice camber to it but moves smoothly, that there might be a little microscopic shift with every bend that we might see as a limp, but sometimes may go unrecognized. And that constant rug burn, that's the analogy I use, whether it is from an acute issue or not, there's a constant rug burn. And there are some key principles that we can address that help reduce that rug burn, either rest or exercise to rebalance the movement, or weight to reduce the total pressure, or bracing to reduce the pressure. When it gets to a surgical approach, the whole idea of osteotomies and joint replacements is to change alignment and pressure. So I think that all of those things play a role, a measurable role. But the way I think about it is definitely around what things create the risk for rug burn inside that knee, and how can we optimize that back to what we think is a normal amount of rug burn and pressure, and that's the youthful young knee that's well balanced with weight, exercise, nutrition, and the like.
Yeah, I think that's a great point, and that's probably the best explanation I've heard of about what arthritis is for our patients in a long time. I totally agree. Like, one of the things, especially in sports medicine, we struggle with is we have patients who come in with arthritis and they say, but I want to be active. And we're challenged with the idea of course we want you to be active. We know that the benefits of exercise far outweigh the risks of being sedentary. And that being said, sometimes the pain is just too much. So just starting off with the different treatment options, you talked a little bit about diet, which we'll get to. What about exercise and activity modifications? What do you tell a patient initially when they come in with arthritis and they say, I don't know, Dr. Scott, am I supposed to exercise more, exercise less? Do you send them to physical therapy? Do you tell them never play pickleball? It's all about doubles tennis. Do you tell them they have to buy a bike?
Yeah. So one of the things you're already alluding to is there's a little bit of personalization, but I think there's some key principles that go a long way for everybody. So in the acute setting, if you're coming in with acute pain, there is a possibility that that pain is from the synovium that is sending out inflammatory markers, and you got your TNF alpha and your IL-1 all circulating around the joint. It may also be from a tissue that's associated with the knee joint being aggravated. I think the one that gets underappreciated because we can't see it on x-ray and it's hard to tell on exam is a bone marrow lesion. You know, I just tell people you might have a bone bruise, a history of osteopenia, you were getting up from a squat and that medial compartment hurts, and it hurts when I hit your medial femoral condyle. There's a real good chance there's a bone bruise in here. So the key principles I use are, let's try chemically to reduce the pain. So that's going to be oral medicines, topical medicines, possibly the use of injections. There are some supplements, which are all chemicals, right? You know, supplements that may be useful, like an ASU, avocado, soybean, unsaponifiable. And then we can try to reduce pain by reducing the load on a joint, which at one end of the extreme is rest. I'll take people off of work. Like, you know, sometimes you got to take that time off of work. Your job is not going to allow this knee to recover, this hip to recover. But as you go on the other side of the spectrum, that includes bracing, unloader braces. We know the science suggests that these aren't awesome tools, but they all add 10%. And then I tell people all the time, this is a quote, I want you to use a cane. It's just a medical device like a cast or brace that we're using temporarily. This is not the beginning of using a cane, but you're too grown to use crutches. You're too grown, so, I try and frame it that way, where we're taking pressure off the joint that way. And that's a way to reduce pain. And then exercise modification in the long term, that's going to really help with function. And that includes, as we know, pain is in all these function scores, these patient-reported outcomes. But there are ways to exercise that are less painful. So low impact, which means don't leave the ground. Resistance, which can be anything from less than body weight up to significantly more than body weight. And we make adjustments there. So I will often have people see a physical therapist because they can help you through the pain. Use, if in the right patient, blood flow restriction therapy and 30% max volume contraction exercises, which is significantly less than what people are doing when they're trying to do weight-bearing exercises that are closer to 50, 60% of their max voluntary contraction strength. And that has been shown to not be more effective in terms of gaining strength, but more effective in having people not quit. So because when you're in PT and you're like, doc, this hurts, perhaps something like blood flow restriction therapy can help modify that. But also, we have our, I'm forgetting the name, but the anti-gravity treadmills, water-based therapy. So, I kind of have my PT offices set up so I know who does the water, who has the anti-gravity treadmill, who has the BFR. Maybe you're going to do this at home with the home program. So, the chemical modification of pain, the reduction of weight, the modification of exercise. Those are the ways that I try and help reduce the pain in the short term. Look, Drew's already telling his friends. He's already sharing the info with his friends.
Yeah, yeah. Well, Drew's got to go to the OR today too, so yeah. We'll cut him some slack. So you mentioned a couple different things about diet. I'm going to cut Drew off because I wasn't sure if
I'm back.
So you mentioned a couple things about diet, and short of just telling patients like you got to lose weight. What I tell patients is, yes, it is a calories in has to be less than calories out, but there are kind of fancier ways to do that. Whether or not it's not just how you eat or how much you eat, but what you eat and how that balances inflammation within your body. So what are the key things you tell patients about diet that you think are really valuable for them to hear more than what they don't want to hear, which is lose 15 pounds?
Yeah. Well, so the this is my everyday. I have specific appointments that are set up that look at nutrition. So, and hopefully this isn't something I'm trying to keep to myself. If this is something that y'all find is helpful, please use this strategy. But the first thing is making sure we set up the expectations. We have evidence that suggests that a 10 to 20% weight loss for individuals whose BMI is over 30, that a 10 to 20% weight loss is going to have up to a 20% improvement in knee pain. And that 20% is based off of a patient-reported outcome, VAS, KOOS, standardized to 10 points. So make it a multiple of 10. So it's not 20% of where you were, it's 2 points on that scale. That's awesome, but it isn't 100%. So if you have 6 out of 10 pain at rest, I'm not, weight isn't going to take you down, likely to a 0. It'll bring you down to a 4. So we set those expectations up. The other thing we do is I tell them, I'm going to go through a list of strategies that my patients came up with, because we actually had a group. We used to do group appointments when I had a certain space. We'd have 4 patients come in at a time. And it was essentially, for the majority of them, it was Weight Watchers. It was accountability, the clear setting of a goal, the use of a calendar to track that goal, and then only focusing on one strategy at a time. Because if you, and we're down in Tennessee, but a lot of people go to church and then their pastor's telling them about, eat fewer calories. And then they go to work and someone's telling them about how we could change the timing of our food with something like intermittent fasting. And then you go to your friends and they tell you about, well, you know what I did is I cut out all the carbs. I'm only eating vegetables. I'm vegan, I'm paleo, I'm keto. And then you try and take one piece of all of these things. For breakfast, you do this. For lunch, you try that strategy. But it's the dilemma of good decision making. If what you're doing does not adequately address the root issue, then any portion of it is incomplete. The story of Solomon. You cut a baby in half, you got no baby. It's not like bread. You cut bread in half, 2 people get a half loaf. When it comes to weight loss, my experience is if you try and cut your effort between 2 strategies before one is a habit, you're failing. You're failing at both. So what we do is we say, let's set a goal, and it is written out from 0 to 20% weight loss within a 2 to 6 month period of time, because that's what the research suggests, is going to help you get a 20% improvement in your KOOS scores. Now, you're going to lose some weight because that's one of the things that's going to go along with this. But I'm looking at it from a knee and hip function, outcome approach. That's what I'm looking at. And when they do this, they say, oh, I want to lose 5 pounds. I go, 5 pounds ain't it. Oh, I lost 5 pounds. That's good. No, the goal was 7. It's very clear on what good is and what isn't good. And because and they know I'm coming with love, nothing but love, but consistency. And they are my favorite appointments at this point, because unlike a surgeon who you may have people come in and go, hey, my knee's feeling great. Thank you, thank you, thank you. For me, when I do my treatment, that's the last I see of them. So all I hear is complaint, complaint, complaint. This hurts, that hurts, this hurts. Now I have currently 5% of my practice. The goal is to get it to 50%. 5% of my practice is just nutrition for weight loss and the treatment of knee and hip osteoarthritis. And they come in every month. And these are anecdotes, but I am going to stress the positive here. We have a mother-daughter team that came in. The mother, she chose to eat from a food standpoint. The strategy was reduce the simple carbohydrates. She changed her whole diet to meat and vegetables. She eats meat and vegetables for breakfast, lunch, and dinner. What she makes at dinner, she saves it for breakfast and lunch the next day. Most Americans aren't used to that idea. She lost 19 pounds in the first month. She's already down greater than 30 pounds at the 3-month mark. And her knee scores have gone down dramatically. Is there placebo? Heck yeah, there's placebo in there. Is there actual improvement in her knee pain? Yeah, there's improvement in her knee pain. Did she also 6 months ago get a steroid injection? Yeah, but we know that's going to wear off if it didn't already. So she has gone from a KOS in the 30s up to a KOS in the 90s. She is not using her cane. She is not using NSAIDs anymore. She has lost at this point more than 30 pounds because she's on track to do so. And she, I didn't start with the initial. She started off at, I'm getting her and her daughter mixed up. I believe she started off at 287 pounds and her daughter started at 310, 312. And her daughter's on track also. So like, it's this awesome approach that focuses on set a goal, pick one strategy, journal it, and then and ultimately make sure that we're staying on track. If you had the time, if you wanted to share the screen, I have the flyers that we hand out up, and I can kind of show those here. But you know,
that definitely tests my Zoom capabilities.
That may not happen. Yeah.
Yeah, the last time I tried to share a screen during a conference, everything went blank for about a minute. So
that's right. Yeah. Well, if as people follow you online and on Twitter, I'm actually live. I pre-scheduled some live tweets, so these things are actually going up as we speak right now.
I'm sure Nirav is tweeting right now too. So
perfect. Where am I? Yeah. Where am I? Where's my equipment? That's not my tray. So. Yeah, but then to more directly answer you, Brian, about what are the strategies, because I really harped on the mindset people have to have, but what are the strategies? Reduce calories by portion control. And the practical way to do that is to get toddler plates. You go to Target, you spend 70 cents a plate, you get toddler plates. You know, you don't have a salad plate anymore. No one gets those anymore. No one is able to change their portions on their own. Well, what about when I go to work? You take a 7-inch sandwich box and you just fill it up. You could put coconut cake in it. I don't care. But it has to be that container and that's it. Strategy number 2, reduce calories by reducing the type of, by drinking only water. So first strategy is reduce calories by portion control of your food. The second is reduce calories by beverages that you drink. We can, as Americans, drop about 25% of our calories just by drinking water. What about coffee? I said water. What about wine? I said water. What about beer? I said water. And that's hard, but you stick to it. Strategy number 3 is now we change the timing of when we eat. Not the amount, but the timing. So we have evidence that suggests that after 8 hours, the body starts to change the proportions at which it burns certain foods because glycogen stores are going down. So we can preferentially burn a higher proportion of fat if we have a 12-hour fast, breakfast and dinner, 2 12-hour fasts, or an 18-hour fast, lunch and dinner with an 18-hour fast. And we stick to that. The 4th strategy is to change the type of food we eat. So primarily reducing carbohydrates, simple carbohydrates, by avoiding anything that's packaged and bread. Bread and packaged foods are not villains. They just aren't useful. They just aren't useful for this team. You know, if you're going to have a whole team of Steph Currys, you're going to have a little bit of issue when you hit that team with the big bodies. So you just pick your team strategically. Right now, we're putting processed food, sugar on the bench, and we're going to focus on roasted vegetables, 400 degrees, 40 minutes, every vegetable except asparagus and radishes, which you do for 25 minutes, garlic powder, pepper, little, a little salt to taste on the radishes. You don't need the salt on the radishes. And you do that plus a nice meat, boom. If you don't like meat, double up the veggies, triple up the veggies. It tastes great. You save what you had in a container for breakfast and lunch the next day. Will you be reducing calories? Yeah, you're reducing calories. But those are kind of the 4 main approaches that we use. And you take your calendar and a red Sharpie, 25 red X's a day. You don't write out what you ate. You just mark out for yourself, did I do my strategy? If you come in with 25 red X's, you will be losing weight, and your knee pain once you hit 10% will be improved measurably and clinically. If you don't hit 25, you know you got to pull that lever more. No one has failed. Everyone has succeeded when they stick to this process.
So I'm guessing that last night I had a slice of pizza around midnight. That does not fall in your diet because it didn't fit fasting, didn't fit the carbohydrates, but it's not a sandwich. So
That's
it's okay, right?
Now, as long as you had water, you're good.
Ooh. Yeah, no, not so much.
Yeah. So that's the thing. Like, so when people go, well, what about the ball game? You know, I just got tickets to see the 49ers, to see the Titans play. You know, holidays coming up, 25 days out of the week or 25 days out of the month. So it's not that you aren't allowed, and we don't call them cheat days. Man, you never cheat. That's no good. But it's just real life days. You know, there's going to be that time where, Drew, you get that, you know, you have a conference to go to, and what do you find when you're in the airport? Like none of these things, right? Unless it's the bottle of water. So you don't end up punishing yourself because these things become habits.
And I think that's great advice. And one of the things I'm asked a lot by patients is like the best anti-inflammatory diet. And, you know, people with mild to moderate arthritis, a lot of them are interested in, you know, eating the right foods or taking the right supplements. And what do you advise people about?
Yeah.
Like, is there something, or is there a supplement to take or something to avoid?
So in general, because I think this next statement will be timeless, the next sentence will be timeless. There is no anti-inflammatory diet. There is none. So like people want to, you know, no matter what, I will probably be correct in that, because we'll just find out it's just food. Like I don't know. But to more directly answer your question, the answer is a diet full of vegetables, up to the point of being a vegan diet. If you look at the alkaline components of diet, an alkaline diet is a vegetarian or vegan diet. When you break out all the little nuances and how people change their definitions, the one thing that carries through is an alkaline diet is one with a bunch of vegetables. We should eat paleo. You know, what is paleo? Vegetables with meat and bacon. You know, what is keto? Vegetables with meat. You know, what studies out of the American Journal of Nutrition, what studies have shown the best improvement for autoimmune arthritis markers? A vegan diet for 3 months followed by a vegetarian or pescatarian diet for 9 months. That's what reduced the ESR levels. That's what reduced other markers. That's what reduced knee pain in that population. A different type of arthritis, but you know, ultimately everyone, and we know this, everyone's looking for that magic diet. Eat your vegetables, like just, and why don't we eat our vegetables? Because no one knows how to cook them. You have to cut them, you got to roast them, or you eat them raw if you like, but you know, I can't eat raw vegetables. It's just not, you know, unless it's avocado, it's just not me. But, you know, I take the time each day, I turn on, you know, CNBC, or I turn on some music and I chop my carrots, I chop my Brussels sprouts. I should literally carry this laptop to the break room and show you my lunch. It's Brussels sprouts, carrots, and a Salisbury steak, which is a hamburger. So yeah, so if you really want an anti-inflammatory diet, the best anti-inflammatory diet is water and vegetables, and eat a huge mix of vegetables so that you can get those complete proteins. And then if you like meat, you add some meat on top of that. And that's the way I'd go.
Yeah, I think it's interesting because these fad diets come up, and I think people often forget, like with paleo, yeah, absolutely. It's kind of going back to our roots, so to say. But if you look at what people ate when we were in that era, we also ate a ton of insects and we ate 100 grams of fiber. What we didn't eat is a burger, 3 slices of bacon, and then a tiny piece of kale just to round it out. It really was eating off the land. And I think, you know, everything you said is absolutely true. And I think one of the things that, you know, we forget about is the size of our plates are massive. Like a dinner plate versus, you know, for us, we've got our large adult plates, but then for the most part, dinner goes on a medium-sized plate. So I think that, you know, that sort of practical advice is huge, because then you just say, well, I got to clear my plate, even if it's a little bit smaller.
Yeah, that toddler plate is crucial, because I don't think we know what salad plates are or where to buy them anymore. They're not included in the set you get during your wedding. So, you know, go into Target, get 70-cent, well, you're in San Francisco, $2 toddler plates.
Yeah, but ours are sustainably sourced, so they're okay.
That's right. they'll biodegrade.
So we don't have too much time, and I'm getting the sense that we probably need to have you on again to talk about all the different injections. But I wanted to ask you one question about, like, when do you decide this is the right time to refer a patient for a joint replacement? How do you run that balance through, you've done the diet, you've done the exercise, you've done the injections, and you can go forward with a clear heart and clear mind that, yes, now a knee replacement or hip replacement is the right option for you?
Yeah, that's in flux. I believe that it is appropriate to help a patient non-operatively until they say they are ready. I'm cool with that. I've read some manuscripts that suggest that once you get to a certain point, you may only be hurting yourself. So that general recommendation of you'll tell me when it's ready may not be right. But for right now, I still think it's okay to use that, because the patient reported outcomes, it could be a bad day and someone comes in with a KOS of 20, they just bumped their knee the wrong way. So I still say, hey, let's try this. The things that start to sway me are if an individual has KL4 changes. And for me, KL4 is bone on bone. For my partner and boss, Rick Wright, KL4, as described in the Meteor study, is less than 50% decrease compared to the other side. I still consider that KL3, but as we all know, the KL grading is subjective. But if it's bone on bone and you have had this pain for a long-standing period of time, so it's not like an acute, I just whacked it on something, I just had a pivot movement. And I don't think you are going to, if you demonstrate or suggest to me that my approach is not the one that you're interested in, I have a bit of a selection bias. People come to me because they know we're going to talk diet, nutrition. But if you come in, you go, oh, I just came because you're the closest, and I got to get to work on the line at GM, then I frequently will go, hey, brother, you need to lose weight because you're a bad surgical candidate, but you're probably going to need a knee replacement. It is hard for me to see this not go into a knee replacement. Am I incorrect some of those times? Yes, there's a woman who worked at GM who had bone on bone, and I'm telling you, bone on bone, attrition. The tibia was essentially a cup at this point. And she got to a point where it didn't hurt anymore. And she just used avocado soybean unsaponifiables, which is a French prescription, but we can get it on Amazon, that helps reduce knee pain and reduce the amount of NSAIDs required. She just used that, and every now and again had a steroid injection, and she had the greatest demeanor, and she just carried on. So it kind of burned itself out. But yeah, to make it brief, if we've done everything conservative and it's continuing, if you are already bone on bone, I'm leaning that way. And especially if you give me some indication that you have advanced arthritis and lifestyle changes are not going to be part of the process for you. And part of that is, quite frankly, let's just call it what it is. I get paid to give you a steroid injection. I hate giving steroid injections. I hate it. I don't care what anyone tells me. JBJS showed reduction in joint space, not a change in pain, but a reduction in joint space after 2 years. I'm not trying to help your knee degrade. Is the steroid hurting your knee? No, it is not hurting your knee. It is making your knee lazy. I don't add lidocaine because I'm not trying to kill more chondrocytes. I do saline and steroid, but I'm not trying to make your knee lazy. So it hurts my spirit when I have patients who just want steroid over and over again, and there's really nowhere else for them to go, and they don't want a knee replacement. So I'm trying to avoid that as much as possible. So yeah, the patients who are not interested in those lifestyle changes and just want the steroid or the knee replacement, I kind of start shipping them off because it's just not my practice. I'm not the perfect doc for them.
Well, thank you so much for your time, Dr. Scott. I think we all learned a lot. I'm going to have to maybe throw out the pizza tonight. And we have to have you back on to talk about all the other parts, PRP, when we use it, what are stem cell therapies. And one thing I'm always interested in is that balance between how patients are actually feeling, and are they depressed because they have arthritis, and how much that gets better with something like diet and weight loss, which we know makes people feel just happy when they look at the scale or look at how they feel. But in the interest of time and Drew's OR practice and your busy clinical practice, thank you very much and have a wonderful day, and we'll chat soon.
Talk soon. Thanks, bud. See you.
Thanks.